Okay, we've got a couple membranes that we have to talk about as well. Only two are really important here. So the first one is the cricothyroid membrane. So it's located. It's going to move up from the trachea. Slideshow. There we go. So the cricothyroid membrane is going to come up along the trachea towards the cricoid and thyroid cartilages. And the reason why you need to know this one is it's the free upper margin of this one that forms the vocal folds. So this cricothyroid membrane is going to come up and it's going to fold inward. And that tissue is going to create a it's directly linked to the vocal folds. The quadrangular membrane is moving the other way. It's coming down the trachea along the epiglottis, and it's going to form the vestibular folds. Now, that's also known as the false vocal folds. There is a little bit of a space then between the vocal folds and the false vocal folds / vestibular folds. And remember, we looked at this in class, and it's basically just a line, essentially. So the ventricle is just, a small line, just a little fold of tissue, and it has a lot of epithelial cells that are important for producing a lot of mucus, a lot of hydration for the vocal folds. This is important because they have to stay hydrated while they're doing the small puffs of air, while they're moving against one another, because that produces a lot of friction, and it's really delicate tissue. So if you don't have enough hydration, this can cause some of the pathologies that we talked about in the very last class, like vocal nodules and also some vocal hemorrhages. Okay, so let's talk about some of these muscles that we need to know. Intrinsic muscles are going to be the ones that are within the larynx. They function directly on the laryngeal function. All of the extrinsic ones are just helping to stabilize. So the ones that you're really on the hook for are these intrinsic ones. You need to know that there are extrinsic muscles, and their goal is to help stabilize the larynx so it can do its job. Remember, it's mobile. It moves when we swallow. It can move around. It can change position to some extent while we're vocalizing as well. But all these external muscles are there to help stabilize it. So if it moves a little bit during phonation, it'll move, say for singing or something like that. It'll move, but then it'll stabilize in that different area. So it's there to help stabilize everything and allow the intrinsic muscles to actually do their job. You can think about these like the erector spinae group when we were talking about breathing. Those are there just to help support the structure and then allow the breathing muscles to do their job. That's what the extrinsic muscles are there for. Okay, thyroarytenoid. What the heck is that? This is... I always put myself in this. I was going to say it's one of the most important muscles, but they're all really important. The thyroarytenoid is the main muscle of the vocal folds. And remember, there are two portions to this. There's the internal and external thyroarytenoid. The internal is also called the vocalis, and the external is called the thyromuscularis. But essentially, the thyroarytenoid is the muscular portion of the vocal folds. Remember, there's 5 layers to the vocal folds. What are they? The top one is the epithelial layer, just a layer of tissue, layer of skin tissue. Then we've got the 3 lamina propria. And then under that, we've got the muscle tissue. And this thyroarytenoid is that muscle tissue. Okay, the posterior cricoarytenoid. Oh, by the way, the thyroarytenoid, let's go back to that really quickly. So the thyroarytenoid are the vocal folds. But they attach at the thyroid cartilage, the angle of the thyroid cartilage, the inside angle of the thyroid cartilage, and the arytenoids. So thyroarytenoid. If you get confused and you forget any of these muscles, they're all named after where they attach. So if you need to draw a little picture of, you know, the cartilages in the larynx, and then you can like draw a line from the thyroid to the arytenoids, that's okay. It'll help you figure out what the thyroarytenoid might be. It's the vocal folds. You should definitely remember that. Like drill yourself on what these muscles are and what they do. Remember, contraction of the thyroarytenoid is going to cause a lower pitch, because contracting this is going to bring the thyroid cartilage up closer to the cricoid cartilage. It's closer to the arytenoids. It's hard to say cricoid cartilage because it's actually attached to the cricoid cartilage, but it's going to bring the thyroid cartilage up closer to the arytenoid cartilages. So that's going to give you a lower pitch. Contraction of the thyroarytenoids, lower pitch. What about the posterior cricoarytenoid? What about this? What does it do? It abducts the vocal folds. So remember, here's our vocal folds. Muscular process is the thumbs because, hey, cool, muscles. The posterior cricoarytenoid is going to pull back. It's going to pull, if you're this way, it's going to pull down on the thumbs. It's going to pull the thumbs towards the forearms is essentially what we can think of this. It's sort of posterior on you that it's pulling, depending on how you're holding this. It's either going to be posterior or down, inferior, one of those, depending on how you're holding your hands. But that's going to pull this way. It's going to abduct the vocal folds, because remember, this is the vocal process right here. So, whoosh, like that, pulling back, opening, and abducting the vocal folds. What about the lateral cricoarytenoids? That's the opposite. That's going to adduct the vocal folds. So that muscle is going to attach to, again, the muscular process, but it's going to attach on the anterior portion of the muscular process. And it's going to pull, it attaches laterally, so it's going to be over here on the side. And so if we're holding it like this, it's going to attach right here. This is going to pull this way, and it's going to adduct the vocal folds. Remember, this is the vocal process, so it's going to adduct and bring the vocal folds together. Okay, there are a few different arytenoid muscles too. How many are there? There are 3. There's actually 2, but there's 2 portions of one of those muscles. So we can talk about it as 3. If you want to split hairs, there's 2. I'm not going to ask you that on the exam, how many are there, and then have 2 and 3 as a possible answer. That would be so mean. I'm not going to do that. Okay, so we have the transverse arytenoid. Remember, transverse is just a cross. Transverse means a cross. So the transverse arytenoid is essentially like hugging the arytenoids together. It's like bear hug around both of the arytenoids. It's just going to cause them to glide together. It's going to hug them like that. The oblique arytenoids is the X-shaped one. Now what it does is it causes the tops of the arytenoids to tilt towards one another. Remember, they're kind of like pyramids, so they're going to tip towards one another because of the oblique arytenoids. Now the oblique arytenoids is actually one ribbon of muscle. It kind of looks like those yellow ribbons or pink ribbons or whatever that people have on their car. It goes up around the epiglottis, around and down. So it's just one muscle. But we have aryepiglottic fibers of that muscle that start above the arytenoids. And what they do are they pull down on the epiglottis, these fibers. So they're going to be one of the major sources of movement of the epiglottis. Okay, the cricothyroid. We have two parts here, if you remember this. Kind of like the oblique arytenoids in a way, except that these look like they aren't connected. They're the pars rectus and pars oblique. Pars rectus is right in the front. You can kind of think about it like your body, right? So if you think about it like your abdomen, you have the rectus abdominis, that's your abs, right in the center. Like you can pat your belly, and that's rectus abdominis. And then you have the obliques, which are off to the sides. And that's true for the cricothyroid muscle too. It's got pars rectus, which is right down the middle, like right where your stomach would be. And then it's got pars oblique, which is off to the sides, just like where your obliques are on your body. Both of these, I should say here, are involved in rotation, but overall, the rectus is only rotating. The rectus abdominis is, or the pars rectus, I got caught in my own metaphor. Sorry about that. The pars rectus is only rotating. Remember, we've got the joint, so we've got a cricoid cartilage here, and we've got a thyroid cartilage here. And the pars rectus is going to pull the thyroid cartilage away from the arytenoids. So if the pars rectus contracts, you get a higher pitch. Remember, if the thyroarytenoids or the vocal folds contract, you get a lower pitch. If the pars rectus contracts, you get a higher pitch. Actually, also the pars oblique. If either of these contract, you get a higher pitch. So the pars oblique is involved a little in rotation, but mostly in gliding. Remember, the thyroid cartilage can also glide on the cricoid cartilage on that same joint. So it has rotation, it's also got some gliding. All right. Now we've got these other muscles that we haven't really focused on a lot, and that's okay. What you need to know is the sternothyroid, thyrohyoid, and inferior constrictor are extrinsic muscles. They're just there to keep everything stabilized. The sternothyroid connects the thyroid cartilage to the sternum. The thyrohyoid connects the thyroid cartilage to the hyoid bone. And the inferior constrictor attaches the thyroid cartilage to the pharyngeal raphe, which we haven't totally talked about yet, but it just kind of comes around and attaches. We'll talk more about that in the next section. What you need to know is that all three of these are extrinsic muscles. The supplementary muscles, like the muscles of the tongue and stuff like that, those stabilize and lift the larynx for swallowing. So they'll help stabilize during phonation. They'll also pull up on the larynx during swallowing. Okay, and that's all you need to know for those non-intrinsic muscles. You need to know the name of those three extrinsic muscles, and you need to know that they're extrinsic muscles. That's it. And then you need to know that they stabilize. Supplementary muscles, I'll just refer to as supplementary muscles. All right. What about some non-speech movements? What about coughing? Coughing is important. So you take a large inhalation and then a tight adduction of the vocal folds. Then forceful contraction of your exhalation muscles. We talked about, these exhalation muscles quite a bit. So you're going to contract the abs. You're going to force a lot of air out of your lungs. And then all of the whatever's in your lungs, if there is anything, pollutants, pollen, little bits of aspirated food or drink, that's all carried out of the lungs by Bernoulli forces, the same forces that cause the vocal folds to come back together, which creates actual phonation. You can create sound with the ventricular folds. The vibration is somewhat similar to the vocal folds. It's less periodic, it's less harmonic, but some singers, those throat singers, can create vocalizations there. Some people with pathologies that don't allow them to use vocal folds will also use the ventricular folds or vestibular folds or false vocal folds. 3 names here. What does the epiglottis do? It basically protects the trachea during swallowing, protects the larynx during swallowing, the trachea, the vocal folds, all of these, the airway. It'll come down and create a tight seal over the vocal folds, which are also going to be tightly adducted during swallowing. That's really the function of the epiglottis. It seems like it doesn't do a lot, and it does just have that one job, but it is an important job. Okay. What is next? Yes, the types of speech sounds. There's actually not a lot of questions about this on the exam. I think there's maybe 2 about this. So turbulent noise, the vocal folds are partially adducted, not touching. So you're not actually going to get like a phonation, but they're close. So what you get is rasps of air. Rasps of air, basically. So no phonation, rasps of air. Just whispers and things like that. Normal speech is quasi-periodic. Vocal folds are adducted a modal amount, typical amount. It's almost a sine wave. It's close to it, but it's not quite. It's quasi-periodic. If you go into the loft register or falsetto, it's the highest pitch. I'm not going to try it because I feel like I won't be able to hit it right now. Anyway, you know what falsetto sounds like. And if you don't, go on YouTube, look up the Bee Gees, and then you'll know. It's the most like a sine wave. It's the most periodic, the loft register. And then vocal fry is very poppy. It's less periodic. It's just kind of like an open and then a quick snap shut. And those are the 3 types of normal speech, not turbulent noise, just typical normal speech. How does the voice change through the lifespan? Pre-puberty, boys and girls are going to be the same. The voice is just going to change with body size. Body gets larger, vocal folds get larger, voice deepens as vocal folds get larger, right? They get longer, basically, because your body's growing. At puberty, though, the male voices are going to deepen due to testosterone. Testosterone is going to cause a change in the... Very simple words have gone out of my brain. Cross-sectional mass. There we go. Testosterone is going to impact the cross-sectional mass of male vocal folds. Or actually, I shouldn't say that. Testosterone is going to change the cross-sectional mass of vocal folds that are exposed to testosterone. So, different males have different amounts of testosterone, and the vocal folds change accordingly. Females also have different amounts of testosterone. The vocal folds change accordingly. So anyway, the voices deepen due to testosterone. That's because of a change in the cross-sectional mass. However, as aging progresses, we see a difference in males and females. So age is just going to loosen the tissue. It's not as tight. It's not as high-pitched as it can be. So you're just going to slowly get a slightly deeper voice for women. For men, that's also going on, but at the same time, there's not as much testosterone in the body, so the vocal folds are going to shrink back to the size they were, or start to shrink back towards the size they were before puberty. And so what ends up happening is that older people are going to have much more similar voice pitches than males and females post-puberty. Okay. So now we're going to look at assessment and also clinical concerns. So the laryngoscope, what the heck is a laryngoscope? Well, it is what you're using to do an assessment of the larynx. You've got two kinds. You've got rigid and flexible. The rigid is going to go just in the mouth and allow you to get a picture of the larynx, a video of the larynx. You can't speak while you're using a rigid one, though, because it's in your mouth. So it's really hard to do that. The flexible endoscope, though, or laryngoscope, I should say, goes up through the nose and then takes a look down at the vocal folds, and you can speak with that one. So you can actually look at all the different movements. Shut up. You can actually look at all the different movements that go along with speech. Okay. So what about when we're looking at, when we're using the laryngoscope, what are we looking for? So some of the things that we're looking for are, what do the edges of the vocal folds look like? We want to see if they are smooth. They should be smooth. They should be a nice pearly white. They should be touching during vocalization, and they should be touching all the way down the glottis. A slight exception to that is for young women. There's going to be a little bit of a slight opening at the anterior portion of the posterior portion of the glottis, just due to age and morphological sex differences. But other than that, you should get a nice closure along the glottis. So that's one of the things you're looking for. You're also looking for mobility. So you want to watch the vocal folds come apart and adduct symmetrically. You want to see them come together symmetrically. You want to see symmetrical movement. If one is moving more than the other, that's indicative of a problem, partial paralysis of one of the vocal folds. You want to look at the health and color of the ligaments and folds as well. So again, the actual vocal ligament, the very edge of the vocal fold, it should be a nice pearly white. If you have blood, if you can see blood in there, or yellowing of the tissue, that's probably indicative of a hemorrhage. The vocal fold should be, a healthy pink skin, just like the rest of the skin of the larynx usually looks. Any change in those is indicative of a pathology. Check out the picture of Reinke's edema in the Phonation 3 slideshow, and you'll see that there's a lot of visible blood vessels that are not exactly ruptured, but they are enlarged and not healthy looking. So in addition to the swelling of the vocal folds, we've also got problems with blood flow to the area. It just is a generally kind of unhealthy look to it. You can also see blood vessels on the vocal folds, which you shouldn't see. That is indicative of a greater propensity to have a hemorrhage, which you don't want. Okay, so what are vocal nodules? Well, vocal nodules are the little bumps that we see on the vocal folds. They're kind of like calluses. They're there from overuse and lack of hydration. So what you usually do for these is just vocal rest. Stop speaking as much, or stop singing, or stop yelling, or whatever you're doing. If they don't go away because of that, there are a few surgeries. You can have them removed with a blade or with a laser. Typically, if this is done, it doesn't ruin the person's ability to speak or sing. There's a lot of high-profile singers that have had surgery to remove nodes, and they're fine. They can still sing just like they used to. Larynx edema. This is a swelling of the non-ligament portion of the vocal folds. So just right off the edge, you get some swelling. This is caused by smoking. It's indicative of smoking. So the smoke comes in, obviously, when you smoke, you inhale the carcinogens, and these tend to not be good for you. So one of many things that they do is they just kind of aggravate the tissue of the larynx, of the vocal folds, and you start to see the swelling after smoking. How do you get this to go away? Tell your client to stop smoking. That's, pretty much the best way to get Larynx edema to stop being a problem is stop smoking. Laryngitis is swelling of the vocal ligament. The vocal ligament gets swollen. It doesn't. It kind of is occluded from closure, and that then causes the inability to speak. The reason why people tend to, with really bad cases of laryngitis, end up just being able to whisper and not actually speak is because the vocal ligament is so swollen that it cannot adduct. And so you're kind of stuck in that turbulent noise zone, and all you can do is whisper. As the swelling goes down, the vocal folds can come together, but they're going to swell again from just little bits of use. So you have a voice for a little bit, and then it gets swollen again, and it won't fully adduct. And so that's laryngitis. Basically, the cure for laryngitis, or the way that we would treat laryngitis, is rest. It's an infection. So you have to do vocal rest. You may have to take something for it. It depends on what's causing it. If it's a viral infection, you probably just have to wait. If you have a bacterial infection, you could probably take an antibiotic. But most of the time, it's overuse. Well, you just have to rest. If it comes from a sickness, usually a flu or something like that, you just have to get over the flu and kind of rest the voice. Okay, intubation. We didn't talk about this one in class. I don't think we talked about any of these last three in class. So we'll go over them right now. Intubation is, of course, when you have to have air given to you because you're not able to breathe on your own. This is a thing that happens in hospitals. Happens a lot more now because of coronavirus. So it's not a good procedure. It's great. It keeps people alive. I'm not saying don't get intubated if you need it, or if you need to be intubated, you have to be intubated. But it can cause some damage that is not as serious as dying, but it is still damage. Some of the things that can happen is it can rupture the folds. It can cause a hemorrhage. Essentially, a hemorrhage, which for some reason I don't have on the slide, is basically just the blood vessels in the vocal folds rupture, and blood is visible in the folds. It doesn't come out. It's not like the vocal folds are bleeding and you're getting blood into your larynx. That's not happening. You're not going to, aspirate blood and choke on it and die. It's inside the lamina propria layers of the vocal folds, and you can see it. This is a hemorrhage. Typically, it just makes somebody sound like they've been yelling a lot. It sounds like laryngitis. It's just a swelling of the vocal folds because of blood. And it's kind of like a bruise also. You'll see that as it begins to heal, it becomes yellow, a little green, just like blood, and then it goes away, or just like a bruise, and then it goes away. And that's a hemorrhage. It looks really gross. It's actually not that bad. A vocal nodule is typically something that you'd be more worried about. Reinke's edema, of course, is not something that you want to have. Intubation can cause those ruptures. It can also cause temporary vocal paralysis. So the vocal folds might not be able to adduct like they should. The arytenoid cartilages are just forced open and apart from each other. So even though you might be trying to bring them together, you have a tube in there that's not allowing them to move. So it can cause temporary paralysis. Very, very few cases of permanent paralysis, but temporary paralysis, yes, that's a thing. Spasmodic dysphonia. Oh, I can't believe we didn't have time to talk about this. It's so interesting. So there's 3 different types of spasmodic dysphonia. There's abductor, adductor, and tremor. And I think you can probably guess what this means. The abductor type means that your vocal folds are going to abduct when you don't want them to. I can't emulate this for you because it's like impossible to do this motion. You just can't. But what's going to happen is you'll hear somebody talking and it'll just kind of sound like their voice is cutting out. I've got a video on this I think it's in the slideshow, Phonation 3. I'll put it up along with this review, just for your interest. I think there's like one question about spasmodic dysphonia. So abductor is you're speaking and the vocal folds are abducting. They're spasming and adducting. And so you stop having that laryngeal buzz kind of off and on. Adductor type of spasmodic dysphonia means that your vocal folds are going to get pressed together more than you would like. So you're speaking and then they are just pressing together. So what you kind of get is a more grating sound with that one, like something like that kind of. That one's a little bit easier to do. And then tremor is a little bit of both of these. You kind of have just like a wavering of the arytenoid cartilages, arytenoid movement essentially. And the waver kind of sounds like that. Diane Rehm is probably the most famous person with spasmodic dysphonia. And she hosted a radio show for years with it. It kind of became her like signature. Anyway, that's what it sounds like. And then the last thing is you can also have, just recently, there have been some documented cases of cricoarytenoid joint arthritis. This is not great. So essentially what happens here is the cricoarytenoid joint gets stuck. If the cricoarytenoid joint gets stuck in the open position, in the abducted position, that's not great. The person isn't going to be able to speak, but that's okay. But the case study that I was reading on this from 2018, I think, was also talking about how the second time that this patient came in with problems with their cricoarytenoid joint, it was stuck in the adducted position or partially adducted position, which means that she wasn't able to get enough air. So they had to inject some antihistamines directly into the larynx, directly at the joint, so like right under the arytenoid cartilages, to try to bring down the swelling, to manage the arthritis so that this person could both speak and breathe. So that's kind of it's very rare, but it's freaky, and it's good to be aware of it in case you ever see it in the course of your career. Okay, so that's the end of the review. I hope you do well. If you know everything in this review, you will do fine. One other thing. If you know everything in this review, you'll do pretty damn good. But the other thing you need to do is you need to do those matching games, because you're also going to be matching up where the muscles are. So this is a review of the content, but you have to play the matching games and figure out, until you get 100% and you know where all the muscles, ligaments, and cartilages are. Consider that just as important a part of the review as this is. Play those matching games until you can get 100%. Remember, you have all day Friday to do the exam. So I would start with quizzing yourself with these PowerPoints. Watch it and then press the forward key and then give your answer and then see what answer I have there. So quiz yourself that way. Also, play the matching games until you get 100%, and then do it a couple hours later and make sure that you're still getting 100%, and then take the exam. You take the exam at 10 p.m. That's cool. You've studied all day. That's great. But you should be able to get 100%. Know what's in here. Play your matching games, and you'll be just fine. Okay. I have to get my recording software up so I can stop it. So I'm just going to keep talking until... there we go. Okay. You'll do fine. Study it. Know it. Take the exam. And I'll see you on Monday, and we'll talk about resonance and articulation.